Good. Okay, good evening. Hello, everybody, and to the folks at home as well. I believe we have it set up so that you can send in questions on the Facebook page, so we'll try to address those as well as from the audience here as well. Okay. So I'll be solo today. Dr. Pink has some laryngitis, so she's with us here, but she'll be, tagging along and jump in if she feels the need. Okay. All right. So we're going to talk about all the details of dry eyes, and we have a lot of new information, so we're going to try to condense it as much as possible. So we listed here the symptoms of dryness. Those all sound common to those of you who are suffering with it. I did emphasize one thing though. I put in highlights, vision disturbance. And the reason is the first sign of dryness is not feeling dryness in the eye. That comes later. The first sign is loss of focus. You'll be reading, looking at your computer. At first you can see, and then after a while it loses focus. And you have to blink to try to clear it up. And that's all associated with the bad tear film. So we want to try to address it in the early stages before all these other bad symptoms develop. So who has dry eyes? The profile of the typical dry eye patient has changed a lot. Back in the days when I was in school, we were taught, well, that's something that older women get from menopause and then just give them teardrops and that's it. Well, obviously there's a whole lot more now. We know about the disease and that it isn't just for ladies, it's men as well, and even young kids. And one of the primary reasons for that is because of all the electronics, the computers, the cell phones. And one of the things that happens is when you're staring at the computer, your blink rate goes way down. You blink 50 to 60% less frequently, and people start doing partial blinks where the lids don't fully shut. So all of those contribute to the dryness. In general, some of the causes of dry eyes include medications, both oral and topical. We treat a lot of eye disease here. For example, glaucoma. A lot of the glaucoma medications and the preservatives can actually make the dryness a little worse. Obviously, patients need to be treated for the glaucoma, but there are some other options on that. For example, there are implants that have glaucoma medicine. We can also special order unpreserved glaucoma medications. There's also surgeries that can be done for glaucoma. So if possible, we try to get away from some of the preservative or even do a combined drop. There's a company that can combine 2 or 3 glaucoma drops into one bottle so you have less preservatives, okay? As far as oral medications, the list includes everything from blood pressure medications, anxiety medication, pain medicines, allergy medicines, anxiety medications, ADHD meds, many. Other medications, and it's really not necessarily a medicine as much as a drug, is one of the most abused drugs, which is caffeine. Caffeine is a diuretic. I'm a user myself. So understand that does dry you a little bit. So does alcohol. There's a lot of other things that go into it. Okay, but we try to minimize those effects whenever possible. Hormonal factors. Certainly, it affects ladies more than men. One of the reasons is as your hormones change, you do have more dry skin, of course, and you get more dry eyes as well. But even for men, it's not just ladies. Men's hormones change as we get older as well. All over the city, you see signs for low testosterone for men. That is true. We do get more dry eyes because of low testosterone. So when it comes to hormone supplementation for ladies especially, if you're on hormone replacement therapy, if it includes a little bit of testosterone, that can actually help the dry eye a little bit. All right. Diet and hydration, of course, it's mostly water. The tears have a lot of water, so we have to be well hydrated. Autoimmune conditions, any inflammation in your body is going to shut down some of your tear production. So anything we can do to reduce that inflammation is going to be beneficial for you. All right. We talked about the blink rate. Okay, neurotrophic keratitis and post-LASIK. So patients who've had LASIK surgery have a unique condition where the LASIK damages the nerve endings on the cornea. And when that happens, the cornea does not sense that it's dry, because when it does, it can tell the brain, I'm dry, make more tears. So you lose that nerve sense, so the eye doesn't produce tears like it normally would. There is a treatment to help regenerate that, and there's also a research study that we're going to start. We'll talk about in a little bit, specifically for patients who've had LASIK surgery. Okay? All right. Environment. In the summer, we're under the ceiling fan. That air is blowing air across your cornea. It dries it out quicker. So try to avoid that, or if you're in the car, don't blow the air right into your eyes. It dries them out more, right? Contact lens wear. One of the reasons that's an issue is contact lenses are like sponges. They suck up moisture. So if you're wearing a contact, you're going to have more trouble with your dryness. In fact, some people, the dryness gets so bad, they literally just stop wearing their contacts. There are some newer contacts that can work good for that, but in general, that is going to be an issue. Okay? Demodex, we're going to talk a little bit more about sleep apnea and sleep deprivation. The sleep apnea, for folks who are using a CPAP that fits over the nose, there usually is a little bit of air that escapes, and that air blows across the cornea overnight and dries the eye out. Okay? So if it's one that fits inside the nose, it tends to work better. Yes? Right. So this patient was commenting that when she got to the ones where it's inside the nostril, a lot less trouble with the dryness. So sleep deprivation, we also noted on there, literally they've done studies on patients who are sleep deprived, and they do have a lot more trouble with dry eye, because when your eye is shut, those hours that you're asleep, the eye can repair a lot of damage that's occurred during the day. So if you're lacking in sleep, your eye is going to be much more prone to irritation. Right? Smoking, obviously the smoke is an irritant to the eye. Nicotinic acid stings and burns the eye. And then of course face masks. Our exhalation blows a little bit of air up across, that's why our glasses fog up, and that makes your eyes more dry as well, because that air is blowing across the surface. Okay? We listed a couple of other things here. I'm not going to go into great detail on all those because we have a lot to cover, but if there's a specific question about one of those, please let me know. Okay? All right. Okay, so the key points that I want you to remember from the seminar, one is, in order to have a good tear film, you have to have full and frequent blinks, because that's what pumps the tears onto the surface of the eyes, the blinking motion. When the lids touch, squirts tears. Okay, so they have to shut fully and frequently. Number two, if there's inflammation, the tear glands shut down. They stop producing tears. So anything we can do to reduce the inflammation is going to be helpful. Okay? Number three, if the glands are physically clogged, the tears cannot get through. Okay? All right. Now, so what is the whole reason for having the tears? What's the purpose of it? So one, of course, is to lubricate the surface. Just like the oil in your car, you need to have some moisture so that when your lid blinks, it glides on the tears and doesn't scrape up the cornea. Okay? Secondly, the tears contain enzymes that kill bacteria and viruses to help protect you from infection. Okay? Also, the tears themselves dilute dirt and dust and contamination from the environment so it doesn't irritate your eye. Okay? And lastly, the cornea has no blood vessels. It gets all of its oxygen and nutrition through the tear film. Right? So it's to nourish the cornea and keep it nice and healthy. Okay? So there's two types of tears. Artificial tears we use routinely because it gives you some relief. It feels good. The problem is they don't contain all the natural enzymes and oils that your natural tears contain. So it's helpful, gives you momentary relief, but obviously we really would rather have more of your own natural tears. They're just healthier for you. Right? Right. So also there's two types of tears. There's the tears you're secreting right now as you're sitting there, as you blink normally. Those contain oils and enzymes and all the nutrients that you need. There's another type of tear that comes from an entirely different tear gland that are called reflex tears. Reflex tears are mostly salt and water. And the reflex tears are to flush the surface of the eye, like an eye wash. Okay? So for example, if you're cutting onions, or you get an eyelash in your eye, or you see a sad movie, you're gonna cry. That's a different tear gland than what we're talking about. Okay? Because you can have a perfectly functioning lacrimal gland that makes the reflex tears, but still be deficient in the meibomian gland, which is the tears you're producing right now. Two different systems, two different glands. Okay? Right. So in the old days, we used to think that most of the dryness was because of lack of water, because the tears are mostly water. If you look at a layer of tears, there's a thin layer of oil, a thick layer of water, and another thin layer of oil up top. So it's mostly water. So in the old days, we thought, okay, if a patient is dry, they don't have enough water. Turns out the newer studies show that up to 80% of the time, the dryness is because of the lack of the oil. because those two oily layers are what holds the water on your eye. Okay? Now, I talked about the meibomian glands and the lacrimal gland. So up in the corner, that kind of cloudy yellowish looking thing up in the corner under the lid, that's the lacrimal gland. That's the one that makes the reflex tears, that flushes the surface. Okay? The meibomian glands that produce the tears that you're sitting and using right now are in the lids themselves. You have about 20 to 25 glands in each lid, and when you blink, it should squirt tears out. Now, where do the tears go? After you produce tears, some of them evaporate, but most of them drain out through the little hole in the corner called the nasolacrimal duct. There's a top one and bottom one. And that's the drainage canal where the tears drain away. From there, they go down to your nose, down to your throat. That's why when you cry, your nose runs, because all the tears are flooding down to your nose and they end up in your throat and you cough because all that fluid is going down there, okay? So, one of the treatments that was developed years ago to help with dry eyes is to plug up that drainage canal. Those are called punctal plugs. And we'll show you a picture of that here in a second. And that basically stops up the drainage canal, just like putting a stopper in the sink, plugs up the hole, and the tear film increases, right? And that can give you some temporary relief. It does not cure the problem, but it can give you some relief, okay? All right. So here's a blow-up of the tear film we talked about. The three main layers are listed there. The oil on top, the aqueous, which is the water, and then the mucin, which is a sticky oil at the bottom. Okay? And it shows a diagram of the tear glands, those long stringy looking things, looks like little caterpillars in the top lid and in the bottom lid as well. Okay? Now, we're going to run this video in just a second, but I want to have you pay attention to a couple things. One is the patient on the video is making nice, full, complete blinks. Okay? Secondly, when they blink, it squirts out a little bit of the oil and the water for the tears. And when they open their eye, you'll see that oil and the fluid slide up across the surface. Spreads out, so now there's a nice tear film. Now that should stay intact for at least 10 to 12 seconds. That's what we call your tear breakup time. How long do your tears stay stable? A person who has dry eyes, their tear film will break up in about 3 or 4 seconds. So very quickly it's already dry. Okay? But this one is going to show you a nice, good blinks, nice healthy tear film. Okay, go ahead and start it. So you see the nice blink, see that oil slick slide up across the surface? That's beautiful, that's what we want to see. This is ideal. Okay, full blinks, you see the oil sliding across the surface, okay? All right, so that's our goal. That's our goal, all right. So, if we look more closely at the lid margin, that's where the glands open up, right on the inner edge of the lid on the top and bottom. And if you look real closely, you can actually see little orange dots along the edge of the lid. I can show you here see these little orange circles. Now, that's the openings of those glands. And you can actually see a little bit of fluid in those glands. This is ideal. Also, the lashes are nice and thick. The color of the lid is normal, like the skin on the face. We're going to compare that to, this is the picture in the middle, and the bottom is the one we just saw. Compare that to this top left corner. One of the things you'll notice is, where are the glands? You can't see those little openings. What's happened is they've been blocked up for so long, the opening of the gland has sealed shut, and the gland is in the process of dying away or atrophying. It's scarring. Okay? Also, there's abnormal blood vessels on the surface. See these red squiggly lines? Those are not present in this bottom picture. So what's happened is this lid has been inflamed for so long that these abnormal vessels are growing over the surface because of the inflammation. Okay? Also, if you notice, the lashes here in this top left corner are going in all different directions. And there's some areas where there's no lashes at all. So one of the signs of a chronic, what we call eyelid margin disease or chronic inflammation in those glands is you start losing lashes. So that's a very common side effect of this meibomian gland disease. Okay? All right. Now, one of the things that we do is we take a picture of the glands. We actually have a high-speed infrared camera that can photograph the glands through the lid. We actually flip your lid and take a picture. Ideally, it should look like this picture here on the left side. I don't know if we can blow that up. Good. So this top left picture, you see those long, stringy looking things, looks like little caterpillars. Those are the glands we're talking about. So again, you should have about 20 to 25 of them here. This is perfect gland structure. Full, straight, well-formed. But when they've been blocked a long time, again, they'll seal shut at the opening, and then the entire gland starts to decay. If you slide it across, slide that across. There we go. If you look at these two last pictures, especially the one on the far right, you can see all that dark gray. That's all scar tissue. Only the little tips of the glands are still remaining. So that's a severe case of gland scarring and atrophy. The problem is those glands do not regrow. There's no way we can regenerate those. So we want to be sure that we treat this before we lose too many glands, okay? Because they're not going to come back. All right. Now, all right, so we talked about how the oil is secreted when you blink. That oil should be like we saw on that video, clear and slippery, silky smooth, okay? But when they've been blocked a long time, the oil that's in there becomes very thick and kind of sludgy. Now, not only does that not spread across the surface, in fact, it gets kind of gooey, it also allows bacteria that live in the glands to overgrow, and very commonly we'll see a staph infection in the crud that's in those glands. Okay? So we want to get that out. And we've known for many years that that was part of the problem with the dryness, was all the crud in the glands. Well, in the old days, there was a way to get that sludge out of there. And that was, we would just take some, they're called forceps, they're kind of like little pliers, and just squeeze the heck out of the gland. Okay? Very uncomfortable for the patient. They actually were able to recruit college students and let them experiment on them, and they found that it took about 30 to 35 pounds per square inch of pressure to squeeze the crud out of those glands. Okay? Now, what we want again is nice clear oil. So I'm going to show you how we used to do it in the old days, okay? So what we're going to see here are these forceps, and they're squeezing the lid. See all that gooey gunk in there? That's not what we want. But removing it certainly helps the patient. And I have to confess, I've done this before in the old days, before we had the new instruments. Patients got better, but they would rarely ask for me to treat them again. It was like a one time and no more. So this was the old days. We would just manually express, it's called, okay? But it's important for you to see what we're trying to achieve is to get that goo out of there, all right? All right, enough on that. So, okay, so how does this process occur? So the glands, again, get clogged up. You don't get enough tears. You start to become symptomatic. The glands become inflamed. They get infected. The eye is real red and irritated. And eventually they scar and die. So that's the process that we're trying to avoid. So one of the things that can happen when we have all that sludge in those glands is the excess oil from those glands accumulates in the lid margins, and that's a breeding ground for a little parasite called Demodex. Demodex is a cousin of the dust mite. So the dust mite, you know, lives on dead skin cells in your bedding. This little critter called Demodex lives on the dead skin cells and dried mucus on the lid margins, in the glands and on the surface, and in the hair follicles of the lashes. Those little critters irritate the heck out of the lid. So when we see this on a patient, we know that there's a lot of problems with those glands. Also, when they have this, they have a much, much higher risk of infection, both in the glands and on the eyeball itself. Okay? And these are actually quite common. A study showed that 20% of 20-year-olds have Demodex in their eyelids, 50% of 50-year-olds, 70% of 70-year-olds. It's very, very common. Okay? There's also some studies that show that this is related to rosacea. So, okay? So, and the reason is the glands on your face, the sebaceous glands on your face, and the meibomian glands in the lid, anatomically are very, very similar. So, how do we get rid of these little rascals? Because what it does, it causes this crystalline debris on the lid margins. You can see how there's looks like little gunk on the lids. Okay? So, how do we get rid of them? Well, whoops, did I jump? I went too far. Okay, so in the old days, doctors would say, hey, use baby shampoo. It does clean the lids. Okay? But the baby shampoo, we blew up the label. It contains what? So I can't even pronounce all these chemicals that are in baby shampoo. Okay? Needless to say, you don't need all that on your eye. Okay? So the baby shampoo can clean the surface, but it's going to also irritate because it's got all these extra chemicals, and it does not kill the Demodex. It gives them a bath, but doesn't kill them. Okay? The only way to kill them is with something that contains either terpenol or tea tree oil. The tea tree oil, or the active ingredient in tea tree oil called terpenol, kills the Demodex. Okay? And there's only a couple of products out there that contain that. One of them is shown here on the bottom corner. It's called Blefadex. There's another new one, I think we might have a picture of it, called Optase. There's another one that's shown here on the slide on this right corner called Oust. All of those contain either tea tree oil or terpenol to kill those little critters. Okay? So first step is to kill those little bugs. Now, once that infestation is removed, then we can use other types of cleansers to keep the lid clean, such as the most common is this OcuSoft lid wipes. There's another one up here called Avanova, which is excellent. That's a great disinfectant to kill bacteria on the lid. Okay? So first step, kill off any Demodex, then use a good quality lid cleaner, not baby shampoo. Okay? All right. Now, what are, other than medical treatments, there's other hints that can really help the dryness. And we put this together because, like, there's a lot of stuff I tell patients that can help them throughout their day. So we'll go through these just briefly. So again, use unpreserved medicine for medications for glaucoma whenever possible. All right. Lifestyle changes. We talked about the diuretics for high blood pressure, anxiety medications, all of these that cause more dryness. Well, what is the best treatment for sleep apnea? Weight loss. Okay? And if you lose weight, then what happens? Less likely to have high blood pressure, less anxiety, right? So healthy lifestyle, exercise, healthy eating, another good reason to do that, right? All right. Healthy stress management, etc. Take breaks from the computer. We know people don't blink normally. So folks who have to work all day on the computer, when you get your lunch break, don't say, oh, okay, now I'm going to check my Facebook. Get off the computer entirely. Go away. Do something else. Your eyes need a break. All right? Right. Washing and drying bedding on high heat to kill any types of dust mites or Demodex that are in there. All right. Air filters. If you run one in your home, especially in your bedroom, that can help with the allergens because those irritate your eye as well. Right? Good quality sunglasses when you're outside. The UV causes thickening and damage to the skin of the lids. The lid skin is very delicate. Okay. And a good seal around your mask as much as possible, or hopefully soon less need for the mask, right? And lash extensions. Folks who have lash extensions have much more trouble. And the reason is they don't want to lose their lashes. So what happens? Either they don't clean their lids at all, or they clean them very, very lightly and they don't really do a very good job of it. So an alternative is there's a prescription medicine called Latisse. Latisse can increase the length and thickness of those lashes, and you're still then able to keep the lids clean. So when I see ladies that come in with the lash extensions, I generally will try to offer them, hey, there's another way to go. Let's try Latisse. Some folks don't tolerate it, but most people actually do very well with it. Okay? All right. All right, so cool pictures. The most important one I'm going to point out to you is the two top left corners. This one says fluorescein staining, the one on the far left, and the one next to it says tear breakup time. Remember I talked about the tear breakup time is how long do your tears stay stable. We put this yellow dye, put a blue light, and it glows this pretty greenish color. So it's easy for us to see your tears. Normally your tears are totally transparent, but with this yellow dye we can see the tears. How much tears do you have? Are they stable? When the eye is severely dry, you start getting this dry dead skin accumulate, and that absorbs the dye. So this bright yellow glowing here at the bottom is actually chapped dead skin on the surface of the cornea. Very uncomfortable. And you can't see good. You're looking through a hazy surface. Right? So this dry dead stuff we call staining, or the more proper name is keratitis. We don't want to see any of this dead stuff. We want it to be smooth. You'll see better, you'll feel better, and the intact skin is a barrier to infection, right? You have bacteria on your skin right now, but they don't cause an infection unless you have a break on the surface, right? You get a scrape or a cut, bacteria can get in there. The same here. Intact skin protects you from those bacteria and viruses, right? This top left corner is a mild version of the staining. You can barely see the yellow. This is a much worse version of it. Now, very commonly, it's kind of like we see here. See where most of that bright yellow is along the bottom, right? And there's several reasons for that. One is patients not shutting their eyes all the way. Two, the bacteria that live on the lid, that bottom lid is laid up right up against here. So those bacteria leach out toxins that sting and burn and irritate the skin. So this is what we look at through the microscope to see how is the surface of the eye. Okay? All right. I'll touch on one other one here, the Schrimmers. See this man with these two little strips of paper? So in the old days, that's how we would measure your tear production. Little strips of litmus paper, and we would see how wet does that strip of paper get. It's still around. We do use that for some research because they require it, but there's way better now ways to measure the tear film. One is the LipiScan, the one I showed you the infrared pictures. We can also measure the tear film there. We can also use on this far right here, I'm kind of in the way, it's a red thread test. It's a tiny little thread instead of that big piece of paper. So there's newer and better ways to measure the tear production. All right, so we talked about inflammation being one of the three problems for dry eyes. Where does the inflammation come from? It can come from external irritants, right? Mold, oak pollen, ragweed, whatever's in the air. It can also come from food you ingest. You know, people are allergic to peanuts, they're gluten sensitive, etc. You intake that into your body and your body reacts against it, causes inflammation. The third is your own body's inflammation. If you have, especially with an autoimmune disease, that's what it is. It's inflammation in your body, your cells attacking itself. Right? So any of those things are going to worsen the dry eye. So therefore, when we see patients that have any kind of autoimmune condition, we pretty much always know there's going to be some dry eye associated with it. Similarly, if a patient has an autoimmune condition that's not being treated, once they get treated, it does tend to help the dry eyes. Right. So, key point, it's a progressive and chronic thing. So we want to educate patients, understand it, know how to manage it going forward. It's not going to go away, but we can certainly make it better and keep you comfortable. All right. I'm going to skip that one. Okay, neurogenic pain. Now, we talked about those nerve endings on the surface of the eye that sense dryness, right? Well, there are times that that patients, even after we treat the dryness, and the cornea now looks smooth, it looks perfect, but the patient says, you know, I still feel discomfort, I still feel something. What that is called neurogenic pain. It's pain in the nerve root. The best example I can give you, it's like if you've known anybody who's ever had shingles. Okay? They get shingles, they get these terrible blisters on their skin, and it hurts. The blisters heal, but sometimes the pain will remain in that nerve root for months and years and sometimes forever. So the nerve pain is deep inside, not just on the surface. Those are treated a little bit differently. There's a few patients that have that, and there are some medicines that are specific for that, but that's not that common. Most of the time, the pain they feel is because there's literally dead skin or something wrong with the surface, okay? All right, now, dry eyes. Very commonly with any kind of chronic disease is to have depression. We added this slide because I see patients, get to know them well. It is a very, very frustrating and depressing thing to have to deal with if there's no hope. Nevertheless, you have to deal with the depression. Sometimes we actually have patients take antidepressants. Now, it can help their mood. It makes the dryness worse, but sometimes it's necessary. But obviously, we want to address that. The best way, of course, is seeing a mental health professional, right? Get somebody that can advocate for you. Increase social interactions, right? The more time we can spend outside with other people, engaging in other activities, it's going to help the depression as well. Okay? All right. Now, I mentioned plugs earlier. Again, those little inserts that go in the drainage tube to help hold the moisture. It can help you feel better temporarily, but it doesn't fix the problem with the glands. But if you have a patient who's very miserable, oftentimes we'll put the plug to give them a little bit of a relief while we continue to treat the underlying problem. It's kind of like the artificial tears. You put the tears in, it feels good for a brief moment, but it doesn't fix the problem, right? It's like the crack on your wall. You can't just patch it. You have to fix the foundation. You can't just keep patching it up. All right. Now, so what are some of the treatment options for the dry eyes? Obviously, we start with the tears and gels because they give you a little bit of relief. But remember, we have to address the inflammation. So that's why there's Restasis and another similar medicine called Xiidra, another new one called Cequa, and there's even generic versions of that. There's many different things we can do to help with the inflammation. You need to be on some type of anti-inflammatory because that's part of the dry eye syndrome. All right? Now, Oral antibiotics. Very often we'll use an oral doxycycline. We use it, and the only other doctors who ever prescribe it are dermatologists for acne and rosacea. Because remember I said the sebaceous glands on your face and the meibomian glands on the lid anatomically function the same way. So what helps this, helps this. Okay? So we prescribe quite a bit of that for patients. It's very low dose. It tends to really help with the meibomian gland disease. Oral supplements. I'm a big believer in omega-3s, also curcumin, turmeric, anti-inflammatories. Good for your skin, good for your joints, good for your dry eyes. Right? Steroids. So steroids are very helpful for dry eyes. However, they are not safe for long-term use. Most steroids we use are just typically short-term to calm the inflammation, make the eye more comfortable. In rare cases do we use steroids for long-term. Sometimes we do, but when we do, we use a much milder one. Okay? So the more mild ones are safer for long-term, but in general, we'd rather use these other ones here that are not steroids. All right? For patients who have autoimmune disease, especially Sjogren's. Sjogren's is an autoimmune disease that causes you to have dry mouth and dry eyes. Okay? There are oral medications that rheumatologists can prescribe that will help produce more saliva, produce more tears as well. Okay? Autologous serum tears. Some of you may have tried that before. Essentially what it is, for patients who are highly sensitive to preservatives, we can send them to the blood bank. They'll draw blood, spin it in a centrifuge, the red blood cells fall to the bottom, and the clear serum stays on top. They take that clear serum, mix it with saline, and give it back to the patient in little bottles. No preservative. We know you won't be allergic to it. It's your own body fluid. Okay? And it can help because it has some growth factors that can help heal the dry skin on the front of the eye. The problem is you have to keep going back to the blood bank to get your blood drawn. Insurance doesn't cover it. And if you have a lot of inflammatory cells in your body, they could be carried over in that serum. So sometimes it's helpful for patients, but not always. I don't use it as much now as I used to because there's another newer alternative that I think is better. We're going to talk about that too. Okay? All right. Lacrosert. Lacrosert, I put it in the presentation and I take it out. And then I put it back in and I take it out. And the reason is it's hard to get it. The manufacturer for a while couldn't get it, and then they brought it back, and then they took it off. But I'll tell you what it is. In theory, it's awesome. In reality, not so much. Here's what it is. It's a dried pellet of oil. Okay? Think of it like, if you make stew and you let it cool to room temperature, you put it in the refrigerator, it gets cold, and it forms like a hard crust. If you take that crust off the top of that soup and you hold it in your hand, your body heat will melt it. It turns into clear liquid. So what these are little pellets that you place inside the bottom lid twice a day. Your body heat melts the pellet, it releases oil. Great in theory. Okay? The problem is you feel a little pellet in your eye all day long. Okay? Second, you have to place the pellet exactly in the right spot or you'll give yourself an abrasion. Okay? So, and then thirdly, as I said, is just the availability of it. The only reason I put it back in is I have seen a couple insurances that required us to have a patient try Lacrosert before they would pay for Restasis or Xiidra and other stuff. So I put it in there in case your insurance requires it, but we don't really use it much. Okay? All right. Okay. Lumify and Upneeq, let's talk about. There's a picture down here of Upneeq. And here's Lumify. So Lumify and Upneeq are related. They cause your eye to look whiter because one of the problems with dry eyes, your eyes get very red, right? So these will temporarily whiten your eye so it looks better. So if a patient has, a wedding they want to go to or some special event, this is fine. It can give you temporary clearing of the redness. But you have to know it's not fixing the problem, right? It's just making it look better, but the problem is still there. So we still have to address it. But to use it occasionally, the Lumify, this one's over the counter, perfectly okay. Now, if a patient has that and they also have droopy lid, either because of a damaged muscle or just age, whatever reason, this one down here, and I'm kind of covering up, is called Upneeq. Whitens the eye and stimulates the lid muscle so that your eye opens wider, which is cool, especially as we get older, our lids droop. We put that in, boom, it looks like you're wide awake. You're alert, okay? Now, ultimately, patients usually will need lid surgery, but this is a temporary way to help the eye just look better. Now, interestingly, this medicine, we're one of the clinics that did the original FDA study to get it approved. So not all doctors work with it, but it is available. It's a good product. Okay? All right. Okay, Oxervate. Oxervate is a liquid version of one of the other things we're going to talk about, which is Procura. I'll talk about that in a second. And then Regenerize Isovis. We'll talk about those. Now, there's other stuff I listed here that are not FDA approved. Some patients ask about it, but I just wanted you to see it is there, not FDA approved. We don't do stuff that's not FDA approved. Okay? If you have specific questions about one of those, I'd be happy to address that. All right, so what other things can we do for the dryness? Of course, the blinking exercises, the warming mask, the stuff that we start everybody on, right? The plugs we talked about, moisture chamber goggles. Moisture chamber goggles are essentially like swim goggles. They're goggles that you put on, and it's got a little rubber seal to hold the moisture and not let any air come through. Okay? So for severe patients, it can help. Or if we have a patient whose eyes are not all that bad, but they go spend a week in Arizona, they'll be miserable. So these can get you through. Okay? All right. We're going to talk about it easily now a little bit more in detail. I listed other stuff that's listed you'll hear about. Again, not FDA approved. If you have specific questions, I'll address that. Okay? All right. All right. Now, Procura. So that's one of the other things we talked about. Procura is really a unique product, and what it is a medicated contact lens made out of human amniotic membrane. So from a full-term healthy baby, they save the placenta, make it into a contact lens. The doctor places it on the eye. We leave it in there from 3 to 5 days. It's approved up to a week, but typically doesn't need that long. The amniotic membrane has the stem cells and growth factors the baby needs to grow healthy new cells rapidly. We put it on your eye, it super accelerates the healing of the dry, dead skin. What would normally take weeks or months, a few days, completely healed. It's amazing. Okay? Now, the other thing that it does, which is unique, is it can regenerate the corneal nerves. Remember I mentioned with LASIK how those nerves are permanently damaged? We thought it was permanently damaged, but a newer study shows that this product can actually regenerate some of those nerves, which is amazing. Okay? We listed some of the uses of it, but those are the times that we will mostly use it. It can also help repair what's called a recurrent erosion. These are patients who had an old injury, a cut, paper cut, poked with a twig, something, and that wound keeps reopening and reopening and reopening. It can help to heal that at a deeper level. Excellent product, okay? But it's covered by insurance, but only when there's actually dead skin on the surface. So if your eyes are dry and you have dry, chapped, dead skin, it'll cover it. But only if that skin is damaged. All right, so this is a kind of a before and after picture. On the top left corner is before, and you can see if you look at the pupil area, the reflection of the light is all scattered. It's all kind of rough looking. It almost looks like the surface of an orange. It's all rough and irregular. Okay? We put the Procura on, and when it's removed, now look how smooth that surface is. You can tell it's a nice clear reflection. Okay? Big difference. This is a picture over my shoulder of the Procura. I'll show you another picture here in a second. Here's another eye. The Procura is on. It's real hazy. After it's healed, look how much clearer and sharp everything is. So certainly this person not only feels better, they see better too. Okay? When we put the Procura on, like on this top over my shoulder here, the top picture, it's a little hazy. When we remove it, it's all goo because all the growth factors are absorbed into the tissue of the cornea of your body, and all the dead stuff is absorbed into the contact. So the contact lens absorbs the crud, the damaged stuff, and nourishes the healthy skin. Okay? All right. So that's called Procura. All right. Eclipse is a dehydrated version of the Procura. We use this too sometimes. The Procura is still the gold standard. It has the best results. But if a patient cannot tolerate that for any reason, this is an alternative. Very much the same idea. It's a little disc, but we place it inside a soft contact. So it's more comfortable, but not as beneficial as the original Procura. But it's another option. Okay? Now something new is there is now a liquid version of the amniotic membrane called Regenerize. You may have, that name may sound familiar. Regenerize is made by Regeneron. A few months ago, when President Trump had COVID, he was treated with monoclonal antibodies from Regeneron, a very, very advanced high-tech biological company. Okay? So they make this liquid version. It's not covered by insurance, okay? But on average, it's about $150 a month for the first couple months, then it goes down to half. So if a patient can't do Procare for whatever reason, this is another way to still get the benefits of the growth factors in a liquid form that you do at home. Okay? Now, excellent product. Right. Now, Oxervate. Oxervate is a lab-created version of those growth factors. Okay? So the Procare, the Eclipse, and the Regenerize are actual biological tissue. This is a lab-created version of that. Very potent. This is only FDA approved, though, for patients who have damaged corneal nerves, like LASIK or some disease that damaged the corneal surface. Okay? I've had quite a few patients on this. It is amazing how well it works. But you have to go through a lot of hoops to get it approved. For those that are a good candidate, it works incredibly well. Okay? This medication costs about $20,000 per eye. Really, so you can see why the insurers don't just approve it like that. We have to go through and show we already tried this, we tried this, we tried this, then they'll cover it. Okay? But it is an excellent product. All right. Okay, Isovis. So one of the things that's typical of any kind of chronic disease, whether it's dry eyes, rheumatoid arthritis, etc., is that it is not the same all the time. Those of you that are suffering with it, you know what I mean. There'll be some days you're okay, we'll treat you, we'll try to get you to a good point, and you'll be okay for a while, but it always hits a bump in the road. There's always a flare-up, right? That can be because of a change in your medication, a change in your diet, a change in your environment. Something triggers it and it gets worse. So when those flare-ups occur, there's a specific medication that was approved by the FDA for those flare-ups. In fact, we did the study on this medicine. Okay? So we know it's a good medicine. This is not uncommon that we'll have people that use this. It really works well. There are in these little handouts, we're going to give you some little bags, and there's little brochures in that talk a little bit more about the medication, but I've had very good results with it. Okay, it's called Isovis, is how you say it. Like, how do you say that word? Isovis, okay? All right. And that's in conjunction with the other stuff we're doing. So it's approved to use up to 2 weeks. It's according to the doctor how he wants you to use it, but it can really help calm that inflammation and get you back to a comfortable level. Okay? All right. Now, when we talk about treating the root cause of the problem again, we're addressing those three underlying factors. Because old treatments like the plugs, for example, and the tears would treat the symptoms but not the root problem, which is the glands, right? So now we're really focusing more on the glands. Now, one of the things that can happen is you're constantly shedding skin cells on the eyelid as well. So some of the dead skin that we said is a breeding ground for that Demodex, that dead skin and dried mucus and makeup for ladies or whoever's wearing makeup can accumulate on the lid and form like a crust. Kind of like on your heel, you get that dead skin and you form that hard crust on your heel. How do you get rid of it? You have to polish it off, like scrape it away. So we do that with a very gentle procedure called Blefex. So here in the corner, you can see all this crud that's accumulated on the lid. After we treat it, the lid margin is nice and clear. We got all the dead stuff off of it. Okay? We do that by using this instrument here right over my shoulder called Blefex. The tip of it is a sterile sponge. The doctor puts a numbing drop in the eye. We turn that on and that little sponge spins around real fast, like an electric toothbrush, real fast. And then we take that little spinning sponge and polish the edge of the lids and the top as well. Okay? You can't do that at home because one, you'll hurt your eye, and two, you don't have that little brush that can get just inside that lid margin with just enough friction to remove the dead stuff, but not enough to hurt your eye. Okay? So here's a little video of it. You can run that. So we put a numbing drop. Is it running? Let me see. Here we go. And we're just polishing that inside edge.
As you go bottom,
I've had it done. It tickles. No pain at all. It feels like if you have an electric toothbrush and you touch your lip with it, you just feel the little vibration.
It does tickle.
That's it.
It does, right?
Okay. And we do all 4 lids.
Getting good.
Okay, we can go on. It takes 10 minutes to treat all 4 lids. Real easy. So that removes all the dead stuff off the surface. Okay?
Good. And then look
Then-
down.
Okay, then the next step is to flush out all the crud that's inside the glands themselves, right? All that sludge that we were showing you earlier. Okay, how do we get rid of that? There's two ways we can do it. One is called lipoflow, and the other one is called tear care. We're going to talk about each of those. So lipoflow was the first one that came out. And again, the purpose of it is to remove the crud out of the glands. One, so you feel better, and two, so they can restore their function so they won't die and scar. Okay? All right. Now, the lipoflow, the way we do it is I put a numbing drop and we place this eyepiece, it looks like a contact lens, under the lid. You close your eye. Place it under the lid, you close your eye, and you just lay back. That contact lens is connected to a computer that monitors the temperature and the pressure. So two things are happening. The contact lens is putting heat into the lid to melt the mucus. So it becomes very thin, like, liquefies it. Then there's the two rubber cushions that massage to extract the crud out. Okay? And the treatment takes 12 minutes. Here we show putting the eyepiece in. Again, I put a numbing drop, have the patient look down, place it under the top lid,
So just look down.
and they
here.
look up, pull the bottom lid down, and there it is, it's on. Then we just take some tape and just tape it across the forehead, and then do the other eye.
That's it. Keep it closed.
That's it.
Perfect.
So the treatment runs for 12 minutes.
One piece of tape.
We're not going to wait to see the whole 12 minutes, so you get the idea. I just wanted to show you what it's like to put the eyepiece in. Real simple.
Close.
All right. So typically we do both eyes at the same time. If it's a patient who's claustrophobic, we can do one at a time, but typically we do them both together. Okay? All right, so here's a close-up of the eyepiece. You can see this white part here looks like a dome, looks like a contact lens. That's the part that goes into the lid. The key is that dome is touching the back of the eyelid but does not rub on your cornea. So you don't feel much at all. Okay? And then the little rubber cushions are here. Now, I'm not going to go through the whole study. I used to, but I'm going to skip over that. I'm going to get to the point. So the point is this. There were two groups of patients. One group just did warming mask. The other group had the lipoflow treatment. After 4 weeks, the group that had the treatment, their gland count increased from on average 6 up to 16. Remember I said we had how many glands, right? So they only had 6 working at the beginning. At the end, they had 16. The other group, the orange guys, were doing the mask only, the warming mask only. Theirs increased to 6 with the mask alone, not much. They had the lipoflow, and then they went up to 11. So essentially what happens is when we do lipoflow, your number of functioning glands increases from 2 to 3 times. Okay? Now, how much it increases is limited by how many glands you have left. And we showed you the picture of some of the dead glands. So obviously the person who's still got a lot of good glands is going to get a better, faster result. The one who has very few glands will still get better, but not as dramatic because they had a lot of dead ones, right? So, all right. Now, a couple things. Is it a safe procedure? Yes, it is. And the reason is the eyeball is protected from the heat. The heat goes into the lid. None of the heat goes into the eye. Also, the massaging is of the lid, not the eyeball. Okay? So, and then lastly, the amount of pressure that those little pads produce is very low. It's about 5.5 pounds per square inch compared to over 30 for the manual expression. Okay? So it's very little. Now, we'll go through this a little bit. In the FDA study, no adverse side effects. The only thing a group related was a few felt a little irritation from the eyepiece, 2%, 2.5%, 2.9%. And any irritation they felt went away without any treatment. Okay? All right. Very safe. Pain, does it hurt? That's a good question. So from 0 to 10, with 10 being severe pain, during the treatment, patients said their pain level was 1.4, really low. As soon as the treatment was over, they said, okay, what's your pain level now? 0.2. So it's essentially painless. I've had it done as well. There is no any pain. You feel something there, but it's by no means painful. Okay? All right. No change in eye pressure. That was important to show the FDA that it's safe. And nobody lost any vision. Okay? All right. Now, again, we talked about how it increases your gland count, takes a couple weeks to kick in. We talked about all this. Now, one of the other key things is patients say, well, once I do the LipiFlow, can I stop doing the warming? Can I stop taking the Restasis? Can I stop doing all the other stuff? The answer is no. Because remember, there's 3 parts to the dry eye. This is addressing the blockages, right? But you still have to address the inflammation and the bad blinks. Right? So you'll still have to continue doing the other stuff. Right. Now, another newer alternative to the LipiFlow is called tear care. So tear care is a little different. Over the eye, there are these 2 little, they almost like little Band-Aids. One goes on the top lid, one goes on the bottom lid. And again, I've had this done too, so has Dr. Pink. So we put that little thing here, and the cord is connected to this little hub that's the power source. So what happens is those little Band-Aids have little wires with little electrodes that warm up. So this puts the heat directly on the lids, right over the glands. What's unique about it is, one is your eyes are open, so you don't have to worry about claustrophobia or anything like that. The other is, as you blink, so the little pads are melting the mucus. As you blink, it oozes the stuff out. Okay? So it's another way to achieve a similar result. The studies show that the tear care is roughly equivalent in outcome to the LipiFlow. So again, here's those eyepieces. This little thing goes down to this little hub down here. That's the power source. Okay. So again, here's another blow up of those eyepieces, and you can see these little, heat sensors in here, and it monitors the temperature during the time. We can adjust the temperature, hotter, cooler, according to the patient's comfort. Right. It's very simple. It works beautifully well. We don't have to worry about if their eyes are too small. Some people, if their eyes are too small, we can't get the other one in. This one's not an issue. All right. All right. And then afterwards, we can still squeeze the glands a little bit if we want to, but we don't have to put much pressure because it's already melted. Then it's just very gentle, and the rest of it comes out. Okay. So that's tear care. So tear care and LipiFlow, think of them as equivalent treatments, slightly different technique, but achieving the same purpose. Okay? All right. Now, so again, what is the goal of these 2 treatments? Again, to remove all the sludge, so you get more tears, you feel better, and it restores their function so they don't die and scar. Right? All right. Is there any pain? None. How long does the treatment last? The studies show it lasts from 3 to 5 years. Okay? It can be repeated anytime, but in general, that's their duration. Now, for comparison, the Blefex, the one that polishes the dead stuff, that can last from 6 to 12 months. Think of that one like going to your dentist and they polish away all the tartar, right? You're supposed to go every 6 months. That's what that's doing. That's polishing the crust away. This one's flushing out the glands. All right, so we know it's safe. Who's a good candidate? As long as you have healthy eyes, no recent surgery, you're a good candidate for the treatment. What's the follow-up? Typically, we see a patient about a month later. Studies show patients get better after a week or 2, better 3 weeks, better 4 weeks. So somewhere around a month, we do their follow-up. Can we do it at all the clinics? So right now, we have 2 clinics have the LipiFlow treatment, and we're going to have 2 other clinics get the tear care treatment. So most of our clinics now will have one or the other. Now, which one is the one for you? That's something that your doctor will discuss with you. Okay? All right. Now, is it a covered procedure? So insurances are going to cover what are called the standard of care, but not every insurance covers everything. Even like dental insurance doesn't cover everything, right? And even medical insurance doesn't cover hearing aids, doesn't cover other things too. So some things are covered, some is not. Well, here we go. So the standard of care is what insurance is legally required to cover. The standard treatment for dry eyes is this: warm towels, right? Warm compress, artificial tears, Restasis or Xiidra, plugs. Basically, that's it. Well, as those of you that are here and online probably know, that's not always enough. In fact, a lot of times it's not enough. So we need to do more. We can do the Procera Regenerize, the Blefex, Oxervate. All of these are above the standard treatments that most people will get. In general, MCO is always above the standard of care. We're always doing more than the average. But of those items, what is not covered is the LipiFlow, and we forgot to add on there the tear care. The Blefex also not covered. The Regenerize also not covered. So these are some of the things that are not covered. In general, we try to do everything that's covered by insurance first. Exhaust all of those options. If we're still not seeing the results we need, we know there's more that can be done. Okay? All right. Now, all right, I'm just going to skip that one. All right. So again, key points to remember. Poor blinks is one of the key reasons for bad dry eyes, right? So be diligent, full with your blinks. Second, remove the blockages with the warming mask and cleaning, and then ultimately the BlephX, tear care, or LipiFlow. And third, reduce the inflammation, right? Internal omega-3s, and externally with an anti-inflammatory eye drop, right? Restasis, Xiidra, Cequa, those, right? And then when there's a flare-up, we bring in the Isovis or similar steroid to calm the inflammation, right? Okay, so, and that's our goal. Now, how does this work logistically? So, when a patient comes in for their regular eye exam, that does not tell us all the details we need to know how bad their dryness is or what's causing it. So what we do, you have your regular eye exam, the doctor says, hey, your eyes look a little bit dry. I want you to start on some basic stuff. And that will usually be artificial tears, warming mask, blinking, omega-3s, okay? All right, which is right here. That's the basics. After that first level, then we'll usually bring on the Restasis or Xiidra or plugs. If that's still not doing enough, and we're going to look at the tear film real closely. I showed you those pictures. We'll take a very good set of pictures of the tear glands, measure the blinks, measure the thickness of the tear film, etc. If they're still not getting enough improvement, we go to the next level. That's the Procara, serum tears, Regenerize, that type of thing. Okay? If we're still not getting enough, then we go to the last level, which is the BlephX, LipiFlow, tear care, and the, okay? So, it's a step-by-step process. We don't just come in first and say, you need LipiFlow. You may not, but we have to address any inflammation and other stuff first, right? All right. So, all right, and again, our goal, just to review, in case somebody missed it at the beginning, is, again, nice full blinks, healthy lids, and that nice, healthy tear film flowing across the surface. Okay? Not only will you see better, you'll feel better, and your eye will be protected. Excellent. Okay, questions? Do we have any come in? No. No, okay. Questions from the folks here? Yes, sir.
How long does it take for the meibomian gland to actually die off, as you said?
Yeah.
Is this a matter of months or years? Because as you're going through 4 steps, obviously you ought to take them the least invasive to start with. But
Sure.
meantime, those glands are probably degenerate.
Right. So when we do the gland imaging, in a 6-month period of time, you usually don't see much difference. In a year, you start seeing a difference. Okay? The problem is, a lot of folks have never had their glands pictured. And it's not really a function of age. For example, I have some patients that are in their 20s that have really a lot severe gland scarring. And then I've had patients in their 60s and 70s who have great glands. You just can't tell by age. It's all the other factors. You know, like even folks, for example, they took Accutane as a teenager. They haven't been on it for 20 years, but it killed those glands. Or they had chemotherapy. They've been cancer-free for 5 years. The glands are dead. So you can't just tell by the age. It's all the other stuff that went into it. Okay? So the strategy that we follow here is plenty of time to get the glands working without more death. It's a slow death, thank goodness. Gives us time to intervene. Yeah.
Tear care the same price as LipiFlow, $500 an eye?
Correct. Yeah. Now, one last thing is a quick commercial. Remember I mentioned earlier about the damage to the nerves from LASIK surgery and the persistent pain, irritation? And I mentioned about a couple of the medicines that we did the original research on. Okay? There's a new study that's coming. We're going to start it next month, I believe. It's called the Sahara study. Aptly named Sahara, like a dry desert, right? But specifically for patients who had LASIK surgery that have persistent dryness or eye irritation, sensitivity, any of those things. In the bags that you're going to hand out, I put the card for the research manager. Her name is Lita. And if you or you know somebody, hey, my brother had LASIK and his eyes are terrible, pass that information along. The patients who enroll in the studies, of course, you get all the care, all the medical care is free, the medicine is free, and you get paid, for your time and trouble. Okay? All right. Okay. Questions? I covered everything so thoroughly? Okay. How do we do on time? Really good. Try to keep it to an hour. We're right on schedule. Okay. Now, how are we doing the drawing? How are you going to do it?
Here, you can sign off for the live video if you want.
Okay. So,
Thank you for.
okay. So, Justine's been keeping track of the folks who logged in online, and then we have a list of all the people that attended here, and then they're going to do drawing and then notify that person. So for confidentiality, we can't say it out loud if it's somebody that's online, but she will contact whoever. So one person is going to get a free BlephX treatment, and then somebody else is going to get either the LipiFlow or Tear Care. Okay? All right. If you have more questions, I can hang around for a little bit. Or you can submit them, online. We can still address those as well. Those that are at home, or even folks here, please share this with friends and family. It's intended to educate, and whether that be y'all or friends, a lot of folks are like, gosh, my sister could really use this information. So please, share the connection with her on Facebook. It'll also be on our website, but usually a week or so later. But it'll already be on Facebook. Okay? Other questions before we go? I think there's food in those boxes. I'm sorry. Justine, you're hogging the food. Okay. Yes.
Did the Tear Care get approval quicker than LipiFlow, or?
They show very comparable results. They almost like mirror each other. When you see the studies, they're like literally one on top of each other as far as how quick and how much improvement.
But they cost the same right now.
They cost the
They're
same.
not considered the standard of care.
Well, LipiFlow was all there was for many years. But now that Tear Care's out and their studies show that it's equivalent result.
Quick question, Dr. O.
Yeah.
On Facebook, somebody said my endocrinologist suggested that I ask about Sjogren's syndrome testing. Are you able to request testing for this condition?
We usually have their endocrinologist or rheumatologist do that. Yeah. Because they have to draw the blood and all that, and we let them do that. Okay, so please get food. Oh my gosh, because we don't have to put it back in the car and take it home.
Do you want to sign off for online? Thank you for tuning in.
Oh, I'm sorry. We're still online. Okay. Thank you all very much. Please share the information. And you don't get food, sorry. Okay, bye.